So like I said, this is really good for us. I mean, especially if we've lived in the South most of our lives. We all know it gets really hot in the summers. Most of our summers, late springs, early falls usually stay around upper 80s, even the 90s. And if we work in the ER, we'll definitely see people coming in having heat exhaustion or heat stroke for sure. All right, so this is the question that I would like for us all to be able to answer by the end of this is just what are some effective ways of treating heat stroke that can reduce mortality and irreversible tissue damage. And if you guys have any questions throughout this, please just interrupt me and I'll happily stop and try to answer the best I can. So this is our sample case. I told Brett, I had to get Brett's permission to use his name in here, and it was a pretty hard fight, but I got it finally. Dr. James is working in the ER in July when a 71-year-old male is brought in by his family after he fainted while watching his grandson play in his baseball tournament. He is currently conscious, but is irritated and disoriented to time and place. He cannot walk on his own. He must be placed in a wheelchair upon arrival. No history of cardiovascular disease. So on your physical exam, you'll get his vitals, and blood pressure was 80/52. Heart rate was 120 pretty much. O2 sats were 98% on room air. And his temperature was 104.1 Fahrenheit. And he was flushed. He was not sweating, tachycardic, as you can tell by 120, and tachypnic. So here's just the title of our article and the authors. So I just want to give a quick background on heat stroke. Obviously, heat stroke is a life-threatening condition. It's marked by you can get pretty severe irreversible tissue damage, neurological, hemorrhagic, liver, and it can cause a wide range of things. Pretty much ends in a multi-organ failure, and also the most important one I think is the cardiovascular failure. As you can see right here, it's one of the main causes of death of heat stroke and heat exhaustion. I think it's characterized by a core body temperature of 40 degrees Celsius, which is about 104 degrees Fahrenheit. That's what the cutoff point is for heat stroke. And so from this, you can probably tell the main way to treat the heat stroke is by cooling the body temperature down, the core body temperature down, to prevent that irreversible tissue damage. And also, since the main cause of death is cardiovascular failure, is to support the underlying circulatory failure. And I'll go into more depth on what exactly I mean by cardiovascular failure is later on in the article, but I just kind of want to put that out there at first. Yes, so heat stroke in this article was kind of classified into two different kinds of heat stroke. The classic heat stroke is what you'll see typically in your elder patients who have been outside for a long time, like our patient in our sample case who's been outside all day watching his grandson play baseball. Usually the elderly population, or even some people who are younger that might have some kind of autonomic dysfunction, have a hard time sweating or even maintaining their body temperature. So these people were more likely to have instances of heat stroke and heat exhaustion. And then your exertional heat stroke, which is usually something that we probably hear more of as younger people, especially any of us who played high school sports that had practice or games during the summer, is the exertional heat stroke. This is usually your athletes, your military personnel, people who are outside exercising a lot, using their muscles, and might stay underhydrated or sweat too much. So I just kind of want to split those up for you guys, just so whenever we're going through, you don't get confused on the kinds of heat strokes that we're talking about. And here's just a chart that was actually in the article that I pulled. It just kind of shows the difference between the two heat strokes. And one thing I want to point you to just for our physical exam is that on classic heat stroke, usually your older people, they'll come with dry skin, because usually by the time they get to the ER, they've used up their sweat stores to cool their body off. So by the time they get in there, their skin's actually dry. And of course, the people who have been exercising a bunch in the heat, they'll be profusely sweating. And the rhabdomyolysis, renal failure, lactic acidosis, and glycemia, hypoglycemia for exertional are all, of course, just from the severe exercise, muscle wasting and stuff. So that's pretty self-explanatory right there. So this article was actually a systemic review. They searched multiple databases. These are just the main ones that they searched, and they even had some articles dating back to 1966. This was actually published in 2007, so it's a bit older article. So the latest we have is 2006. But they pretty much just looked through all these databases for any kind of review or study that had original data, and they had to have more than 10 patients, as you see down here, for the eligibility. And there's kind of a second part to this article that I wanted to mention was the hemodynamic support. I'm sure in the ER it's hard to have a randomized controlled trial for treating heat stroke and stuff because usually these are pretty emergent cases. So they only had to have 5 people, which I don't think I put that in here. But also the pressures of the heart and the circulatory system had to be measured by central venous or pulmonary artery catheters. So I kind of went through this and kind of divided up. So as you can see, these are the cooling methods that they tested or the observational studies that they looked at. You have immersion in cold water, cold pack application, evaporative cooling method, and other pharmacological treatments. So these are just the 3 methods that they, or the 4 methods that they looked at in the studies for trying to find out which one was more effective. So I also want to point this out, the immersion in cold water and the cold pack application, those 2 together are considered conductive cooling methods. And then, of course, evaporative is different. There's some studies that kind of compare these 2, just conductive in general to evaporative. So when I say conductive later on in the results, I'm talking about immersion in cold water and cold pack application. And this is just kind of analysis to see how many studies they had for each one that studied just those cooling methods. All right, so pretty much getting to the meat of what we're going to be talking about here is the results. So in the classic heat stroke, this is, like I said, the people who, usually the elderly people who have been out in the sun all day, the effects of evaporative cooling methods were actually tolerated better. But as you can see down here, the conductive methods, the immersion in cold water and the cold packs, were actually more effective at lowering the core body temperature. But because usually whenever you have an elderly patient, you try to stick them in a bucket of ice water, they're not going to tolerate it themselves as well as just the evaporative. And a side note, there's actually a whole paragraph in this article talking about what they mean by not tolerated as well. In some cases, they had to bring in nurses and technicians just to kind of hold these patients into the ice bucket or even to hold the cold packs on them because the elderly people would get agitated and even get kind of combative with the doctors and nurses. They sometimes even had to sedate them. And also research does show that these evaporative cooling methods actually decrease the mortality rate. So overall, it's better and they're less combative. So it's kind of a win-win for us there. Non-invasive methods, ice packs, wet gauze, or just a fan. These are things that we can use. This is a case, they had a case where a nursing home went out to I think it was an amusement park one day, and 6 or 7 of them at one time were all having a heat stroke, which is just catastrophic. They had to use these packs on the bus when headed back. They all had to get ice packs from the amusement park and stuff. So they actually had some research over that, believe it or not. And thank the Lord, none of them had any problems. But if you were an athlete, of course, during the summer practicing or playing sports, I remember whenever I played football in high school, there was always 2 or 3 just huge ice water buckets just out by practice. And research actually shows that people who are having the exertional heat stroke, or athletes or military personnel, the most effective way to lower their core body temperature is immersion in the ice water. And then I just kind of reiterate that this conductive method is not as well for classic heat stroke. So they also tried to use pharmacological treatments to kind of cool the core body temperature down. Any of us who have done sketchy pharm know what dantrolene does, but in case you don't, it just prevents calcium release, which would then, so it's used mostly in malignant hypothermia or neuroleptic malignant syndrome to kind of lower the core body temperature down. And it actually showed that there was no decrease in mortality and morbidity when using this dantrolene. It was usually used as adjunctive therapy, but when comparing just, doing the evaporative cooling method with elderly people with or without dantrolene, there was actually no benefit to using the dantrolene. And some people might think, well, if I use an NSAID or aspirin acetaminophen since it lowers fever, could I use that to lower my core body temperature? And actually, they recommend against that because with heat stroke, you have the whole just multi-organ system failure pretty much happening, which could then lead to coagulopathies and liver failure. And taking these NSAIDs could actually aggravate either one of those, coagulopathy and liver failure. So do not use acetaminophen and aspirin NSAIDs in general. So the last point was kind of more towards the hemodynamic support of treating heat stroke. If a patient came in with heat stroke and they had hypotension, they were at a much higher risk of dying than people that did not have hypotension. And it mentions that the mechanism behind this hypotension is kind of like distributive shock, where all the blood pools in the cutaneous vessels due to vasodilation and just drops your blood pressure down. And so you would think that maybe if I give them some kind of vasoactive medication, something that constricts their blood vessels to get that blood pressure up, maybe that would help. But it actually shows that using these medications increase the chances of dying in neurologic morbidity. So it proved that fluids resuscitation actually for hemodynamic support was actually the best way to restore the blood pressure and tissue perfusion. So I kind of threw a bunch of results at you. So this one slide kind of just summarizes in general, just like what all the results said. I think the most important one is that this is not just, oh, if I just put them in an ice bucket, they'll be fine. You need to have also the hemodynamic support with the cooling methods. So fluid resuscitation is probably the best way we can do this. And the study actually said that there is no research telling which one, like which kind of fluid is best. So I would just assume that as of right now, just normal saline is probably fine, maybe even some chilled saline. So use that as you're also trying to cool down the body from the outside. Immediate immersion in ice water for the young, healthy individuals is the best for exertional heat stroke. It's actually proven to reduce mortality and morbidity. And so I mentioned the evaporative cooling methods earlier, but I want to make sure I told you exactly what that was, because I was making this and I got to this point, I was like, well, I never actually talked about what evaporative cooling method is. So this is when you just, if you have a patient, usually use this in your elderly patients who come with classic heat stroke, just run some gauze under some cold water and apply it on the skin, and then have a fan facing them. And like I mentioned, this is way better tolerated by the patients and also decreases morbidity and mortality. And finally, pharmacological treatment, whether it's the cooling with dantrolene or the hemodynamic control, just medications in general have been suggested to actually be worse and ineffective in treating heat stroke. So this is probably one of the few times we can just say, oh, if we give them some medicine, it might help them out. This one's all usually just from the outside, and then also with the hemodynamic support of fluids. Now, that pretty much does it for the conclusions. I'm just going to kind of finish up with the limitations of the study. As you can see there, they didn't have well-designed controlled studies comparing, like they didn't have a design study comparing evaporative to conductive methods for treating classical heat stroke, but just based off the data compared to all these studies, that they just made recommendations based off that. And also these are made mostly off of observational case series that lack control groups. There's no control saying whether if we didn't do this, if it would help or not. So that's just the limitations of the study. And I wanted to finish up with some discussion questions. First, I just want to say, like, do you feel like this presentation kind of helped you feel more confident in that you know how to treat a patient that presents with heat stroke? I hope you do, at least. And also, let's say that you were actually a physician, you're out there watching your son play baseball, and you notice an elderly man like this pass out and faint, and he's showing, that's my Siri. You're actually out in the at the ballpark, and you see this man pass out, and you suspect heat stroke. What are some methods that you think you could possibly do outside of the hospital to lower this man's, or a female's in this cases, or a different case, lowering their core body temperature? Can you guys think of some ways that could possibly happen, or possibly lower the core body temperature without the hospital?
Remove him from the environment first.
So yeah, I looked at some ways, and I was also kind of hoping that you guys would come up with new ways that I didn't even think of, but I would definitely say remove them from the hot environment is probably, number one. Have someone turn on their car to get the AC flowing and try to get this person out of the hot environment. That's definitely a good way to do that. Any other ideas, guys?
This would be similar to the evaporative cooling technique, but maybe you could just soak get a t-shirt wet or something and apply it.
Yeah.
Kind of over the chest or extremities or wherever.
Yeah, this was something that I found looking up too. Is that that's actually pretty much it. You know, get in like in ice water, and if you have to Gatorade, and like they're gonna be sticky, which would suck, but they would probably prefer being sticky over being dead, obviously. But they say that the best places to put them um, is in the groin area, under the armpits, in the back of the neck, and the front end of the neck, areas that big vessels pass through that can actually cool the body down better. Any other ideas, guys?
Yeah, I think what Lane said is probably the first go-to thing. One thing I would say is be careful in like this day of age of what you use to lay on the patient. I know it's common now, especially out in sports fields, where you get like the silicone towels that a lot of people are using now. Silicone allergies are not uncommon. Actually, whenever I was in high school and college, we had several people who tried to use the silicone towels, and it would just, where they would lay the towel would be covered in blisters and boils after they got done using it because of the silicone allergy.
I did not know that. So yeah, it's good to know. Yeah, so what I had in mind was what Jonathan said was take them out of the environment, and if you can get ice water and put it on some cold rags, even some ice packs, and just put them in these areas of big vessels. So that's what I had. That's what I was thinking of. But if you guys can think of anything that could possibly work, I mean, we're all going to be outside in the hot one of these days, and we might actually encounter this. So just having all the ideas possible is best. So if any more ideas, I would love to hear them.
I think it's important to like not forget your first aid training, because like you said, cardiovascular collapse is almost like a hallmark of this in really severe cases.
Yeah.
So checking pulses, because you're saying this guy just went down, like, so you need to see if he has a pulse, because you might not be doing cooling methods, you might be doing CPR.
Yeah, that's true. Always check the pulse and stuff, of course.
And I also feel like this is probably an instance where if you're seeing a lot of the signs of this, and if it's someone who'd be particularly susceptible, where you need to also be calling 911 while you're doing these wet t-shirt, getting them out of the sun, that sort of thing.
Yeah. So just a little small thing I want to say too is I never actually mentioned like the actual symptoms of someone having the heat stroke or heat exhaustion, which was not the focus of this study at all. So that's why I kind of didn't mention it. But I would say the most important one is, people will faint, of course, just because of the hemodynamic collapse, pretty much like what Jace just mentioned. Neurological symptoms are just, if they're conscious, they are going to be confused. They're not going to know what's going on. They might even not know who they are. I mean, it's just any kind of neurological collapse, pretty much just because the brain and other parts of the body are not getting blood. Also, tachycardic. And I don't know why you never put a blood pressure cuff out in the field, but if you happen to have one, the blood pressure is going to be super low because of the vasodilation. And that's just the main ones that you'll probably see. There's a bunch of other ones, that like biochemical ways, but you're not going to see that, of course, in the field. That's all I have for you guys, unless Jason wants to say anything.
Yeah, I have a add at the end that I think you did an awesome job. I think this was a great topic that I think is super relevant to emergency practice, especially in health. So great job. Congratulations. Just a couple like practice pearls I'll add from the IMRA EM fundamentals that I think are just interesting. One thing that they really stress is that I'll sort of imply from what they're stressing is that it's really important to take a thorough history in these patients, even though it is an emergency, because you need to have a high clinical suspicion for both this and sepsis. And the who comes in with tachycardia, hypotension, altered mental status. So all of those things will also trigger like your sepsis protocols.
Yeah.
One thing that they make a note of that I thought was really interesting was treat the hypotension with discrete IV boluses of isotonic crystalloids, which you mentioned, but they make another note of saying not to use pressors.
Yeah.
So not using pressors for blood pressure support allows you to dissipate heat in your extremities better. So that's a big difference between how you would manage a hemodynamically unstable patient in septic shock versus someone with pretty severe heat stroke. So I think taking a thorough history and doing the rest of your diagnostic workup, looking for sources of infection while you're working to actively cool this patient, I think is really high yield.